hospitals across England, and we've been at about that number for the last fortnight. As a reminder, that's obviously a very sharp acceleration since Christmas. We had around 18,000 positive coronavirus patients in hospital at Christmas time. And although we're beginning to see new admissions beginning to turn down slightly, the beds occupied that are decreasing slightly in London are nevertheless being offset by increases in the Midlands, for example. So overall, we're right now sort of about plateaued at about 33,000 COVID positive inpatients, which is an incredibly high number and very, very serious. And when you look at the critical care position, again, we've got over 4,000 patients in critical care, and about 3/4 of our critical care patients are there for COVID-related reasons. So, you know, if you look back since summer, beginning of July, August, first half of September, those COVID inpatient numbers were right down. We then began to see the increase going into October. By mid-November, we were at about 15,000 coronavirus inpatients. We hoped that the numbers would then come down as we headed into Christmas. Instead, we saw they were stuck at about 15,000 for another month until mid-December, and then this huge acceleration since Christmas, as I say. So a very serious position with all kinds of knock-on consequences, not only for patients and families with coronavirus, but other services as well.
And we know the pressure's slightly easing nationally at the moment, but as things stand, are you still confident that we will be able to find intensive care beds and ventilators for everyone who needs them?
Everybody is getting intensive care and ventilators who clinicians think would benefit, but let's not disguise the fact that this is obviously stretching the system in an extreme way. So we have got about 3,700 core critical care beds across the NHS in England. And as a result of the work that hospitals did to prepare over summer and autumn, we've got surge beds and facilities, of which we've now got about 2,170 occupied by patients who need critical care. So said another way, more than 50% of critical care beds on top of the core capacity. And that is obviously requiring a flex in staffing levels, and staff are working under incredible pressure to deliver those services.
Thank you. Well, let's talk about the impact on some of those other services. So start with Paul Bristow.
Thank you, Chair, and thank you, Sir Simon. What steps are you currently taking to maintain as much cancer treatment as possible?
Well, I think the first thing to say is that during autumn and early winter, we saw a very good rebound in the number of urgent cancer referrals coming back into the system. And since March, around 1.3 million patients have been urgently referred for a cancer check, of whom 9 out of 10 have been seen within a fortnight. But to answer your question directly, the area we're most concerned about is cancer surgery. Chemotherapy and radiotherapy, I think, are continuing, and for the most part, in an uninterrupted fashion. But cancer surgery, and in particular, patients who need an operation within a month, so-called P2 categorized patients, those are the patients for whom everybody is doing everything possible to create dedicated surgical facilities, surgical hubs in some parts of the country, to make use of the independent sector hospital capacity that we've also contracted, and to make sure that if an individual hospital needs to ask for support from another hospital, then the patients get that care elsewhere. So there is huge focus right across the health service on trying to make sure those services are sustained. Obviously, there's particular pressure on anaesthetists at the moment, many of whom are being diverted to help the critical care surge for coronavirus patients.
Okay, on that particular point about cancer elective surgery, I think it's Professor Neil Mortensen, the President of the Royal College of Surgeons, is quoted by somebody saying that not enough private sector capacity have been secured. Is he right?
Not at this point. I don't believe he is, no, because we've got the ability to make use of whatever independent sector capacity in a particular city or area is deemed necessary by the local services. I think it's less a question of facilities and more a question of people. And of course, as you know, as Bristow, as Professor Mortensen will know, the surgeons and anaesthetists, for the most part, who operate privately are exactly the same surgeons and anaesthetists who would also be providing care within the National Health Service.
Yeah, well, that's right. I mean, and on that, there was a leaked letter I read the other day to the HSJ that suggests non-urgent elective activity in the NHS is continuing in the independent sector. Wouldn't this capacity be better used to deal with some of these urgent cancer surgeries?
Well, that's exactly what's happening. So the hospitals across the country are prioritising those urgent operations through the independent sector, and particularly since Christmas, as there's been this big surge in COVID inpatients, that is the reprioritisation which is happening. I think it's worth saying that although there are pressures right across the health service, you do see the differential impact of a high coronavirus number of patients in particular parts of the country. And so just to put that in context, in London, the southeast and the east of England, at the moment, for every one coronavirus patient we're looking after in hospital, we're looking after 2 non-coronavirus patients. Whereas in the northeast and Yorkshire, the southwest regions where coronavirus has been more under control, that instead is a ratio of more like 1 coronavirus patient to 3 non-coronavirus patients, or 4 non-coronavirus patients. So the single biggest thing we can do to make sure that the full range of services can continue to be provided is to get the infection rate down, and hence the COVID hospitalisations.
Okay, just one final question, if I may. You say that this is what's happening at the moment. Why do you think so many why do you think NHS officials and NHS England officials and people felt the need to write that letter then? And why do you think it was leaked to the HSJ?
Well, as I say, I just described the facts, Paul. So the facts are that right across the service, people are looking at those so-called P2, the urgent operations that are needed to get done, and are moving heaven and earth to get them done. That, I think, is the fact of the matter.
Okay, thanks very much.
Thank you. Laura Trott.
Thank you, Chair. Sir Stevens, what's your assessment of the impact on maternity services during the pandemic?
Well, I think the first thing to say is that obviously maternity services, in terms of the childbirth services, continue throughout. There have been some freestanding midwifery units, or alongside birthing units, home birth services that have been disrupted as a consequence. And obviously there's been an ongoing debate about visitors for partners of women who are pregnant to maternity units during the course of the pandemic. On the objective data on outcomes, the initial figures from the Office of National Statistics suggest that the quality of care has continued to improve, certainly between January and September, in line with the trends that we've previously seen, which is encouraging if sustained. But look, I mean, there's no part of the health service that has not been affected in some way, and that's certainly true of maternity care.
Data seems to suggest that the stillbirth rate nearly doubled last year. How would you and your service be looking to address this and making sure that the women, the partners and the families affected have the correct mental health support afterwards?
Yeah, so maybe I can take those in 2 parts then, because as I say, I think the ONS data that we have from January to September suggests that the stillbirth rate has continued to come down. But in terms of maternal mental health services, obviously a big part of the investment programme in mental health in the round is upgrading perinatal specialist mental health services, and those have continued to expand during the course of the pandemic. The area, frankly, in mental health services where we're seeing real pressure, I would say, is increasing referrals, urgent referrals for eating disorder services. And although we've had improvements in access to those services over the last several years, I mean, they are now really under pressure. And we have another £500 million that the Chancellor made available in the last spending review to invest for these extra mental health needs during the course of next year. And those eating disorder services for young people will, I think, be towards the front of the queue for that.
Thank you.
James Davis.
Thank you, Chair. Sir Simon, I'm interested in the impact of the pandemic on very long waits for procedures. I think it's fair to say that before the pandemic, there were very few instances of patients waiting over a year for treatment in the NHS. But a report in the Health Services Journal recently suggests that nearly 250,000 people are waiting that length of time. I wonder if you could please confirm that that's the case and give some kind of indication as to the median wait for those waiting over a year and perhaps the maximum wait. Thank you.
Yes, certainly. So I think it's a mixed picture overall on waiting times for routine care. The biggest impact, as you rightly say, is that the number of people waiting 52 weeks or above has shot up during the pandemic as a result of disruptions to non-urgent care. And for the figures just reported at the end of for November 2020, that stood at 192,000, and a year before it was under 2,000. So that is, very, very impactful. Two other points just to put alongside that, though. The overall size of the waiting list, the number of people on the waiting list, is actually, when you account for estimates for missing data, slightly lower still now than it was a year ago overall. And the median wait for a planned test or operation has actually been falling quite substantially since July. So in July, after the effect of the March, April, May bulge in coronavirus was felt, the median wait for planned care was over 19 weeks, and that had fallen to around 10.5 weeks by November. So the health service used the summer respite from coronavirus very well to rapidly re-establish diagnostic and planned care to get the average wait down very significantly.
I understand that, and certainly many people have been working hard to try to ensure waiting times are kept at a reasonable length, but there is still a cohort of patients waiting over a year, and because of the way the statistics are published, it's not entirely clear how long they are waiting. Is it possible that you could contact us, could write to us with further detail on that?
Sure, yeah, of course, absolutely. By the way, I think it is possible to decompose those data from the published, but I'll certainly get that to you. Yeah.
Thank you.
Thank you very much. We're now going to move on to the vaccine distribution programme, and Greg Clark is going to lead off.
Thank you, Jeremy. And perhaps, Simon, I could echo Jeremy's thanks to you and to all of the staff right across the NHS and indeed the care system. The vaccine rollout being a prime example of the extraordinary mobilisation that is achieving such good results. But on that, we've heard overnight from the European Union that there are moves afoot to put bureaucratic obstacles in place to the delivery of vaccines manufactured on the continent. Are you worried by that?
Well, were that to happen, then of course that would be a worry. But as I think government ministers out on the airwaves this morning have said, they think that that's not something that is at the moment likely. The reality is that, as you say, we're off to a strong start with vaccination. Actually, we have a shared interest in every country doing well on vaccination, given that the virus moves across borders with extreme ease. But equally, this country did well to secure vaccine supply from multiple sources. Our regulator did well to expeditiously but authoritatively look at the safety and efficacy data. And I think GPs and hospitals and all of our partners are doing well to get the vaccinations now underway quickly. So we don't want any of that progress stymied, while not, of course, wanting to see slow vaccination anywhere else in the world either. We all benefit from significant vaccination uptake everywhere.
Would it prevent the attainment of the 15th of February target for the most vulnerable groups if such obstacles were put in place?
Well, we are on track for the 15th of February, and as I think Nadeem Zahawi said this morning, that remains our line of sight to the 15th of February. But clearly, we have a combination of sourcing from Oxford AstraZeneca, principally out of this country, and from Pfizer-BioNTech from continental Europe. I mean, I think one of the things that arises from this, and indeed, since I know you're more broadly thinking about the lessons of the pandemic, is that alongside international cooperation, actually having strong UK manufacturing capability, including in life sciences, is an important part of our future resilience. And very extended supply chains do not necessarily serve you well.
Thank you. The Oxford vaccine, great triumph of scientific endeavour and discovery, has now been administered to over 80s in the UK since the 4th of January. 3.5 weeks on, are you aware of any hospital admissions of people who've had the AZ vaccine?
Well, there of course will be hospital admissions for people who have had vaccines for a whole range of reasons, but the pharmacovigilance process that MHRA have put in place with the support of those who are giving the vaccines is continuing to report. And at this stage, there is nothing of concern. I know MHRA will be publishing their pharmacovigilance data shortly. Obviously, we took particular care in the first several days after both vaccines were authorised. We began by administering in hospital hubs so that we could be sure that if there were to be any significant allergic reaction, then the full support and backup would be available. That on both counts has gone very smoothly since then.
I'm thinking in particular of people admitted for COVID. Are you aware of anyone, whether it's the Oxford vaccine or the Pfizer vaccine, that's been admitted since they've had the either of these vaccines for COVID reasons?
I don't have those figures in front of me, Mr. Clark, but I mean, to state, as you well know, there will be people who within the first fortnight or so of having had their vaccine will go on to contract COVID infection, because the immune response particularly kicks in after a 12 to 14 day period. So there will be those individuals, and the question, of course, is making sure that the curves diverge, which is what the trial data showed in both cases.
Indeed, and we're in a position as time goes on to be able to establish pretty comprehensively how effective these vaccines are, and to quash the suggestion. We hope that there's anything in these suggestions that they're not efficacious. So that data is very important. Yes. Would perhaps you might write to our joint committees with this as soon as possible, because I think that would be tremendously reassuring.
Yes, well, I'll certainly ask June Rain to do so, because it's obviously MHRA who are leading the continuing post-authorization surveillance.
Absolutely. And just thinking about the pressure on hospitals, you were very clear that that pressure continues, it's stabilized. Would you say something about the composition of patients, both in intensive care and generally? Are they mostly the very elderly, or is it more evenly distributed than that?
Well, that's an important question that, of course, connects to some of the wider policy debates then about what the sort of future regime for reducing social transmission looks like. So I suspect that might be the question behind the question. But in terms of the figures, as I've previously said, about a quarter of hospital admissions for COVID are for people aged under 55. and about half of inpatient bed days for coronavirus patients relate to patients under the age of 65. So clearly deaths are highly concentrated in the older age groups who are in the first 4 categories of high priority recommended by the Joint Committee on Vaccination and Immunisation. That is people aged 70 and above, the clinically extremely vulnerable, and the health and social care staff looking after them. And independently, that's been estimated to account for 88% of the deaths that have occurred so far. But when you look at the use of hospital resources, it's not quite as concentrated at the apex of the pyramid of risk, shall we say.
So if our aim is to reduce the pressure on hospitals, as well as obviously reducing deaths, then we need to make sure that not just the over 70s are protected, but lower age groups as well. That follows. I'll take it.
Yes. So can I just also clarify the answer I just gave? When I said half of coronavirus-related bed days, that was in critical care for the under 65s. For general hospital beds, acute beds, it is more like a quarter of bed days that are for people under 65. So in other words, by the time you are vaccinating people 65, 70, 75, you're beginning to make a big impact on the hospital bed usage, not just the avoidable deaths.
So when it gets to the point that hopefully soon that we've vaccinated all of the over 70s and the people that are extremely clinically vulnerable, is the logic of reducing pressure on the NHS to actually vaccinate next, perhaps those in their 60s and perhaps over 55s?
Yes, that is the logic, and I think that is the current proposition, that once we have offered vaccination to everybody aged 70 and above and the clinically extremely vulnerable, then the next group of people would be people in their 60s and 50s, although there will also be a legitimate discussion, in my view, that the Joint Committee on Vaccination and Immunisation will have to advise on as to whether or not there are certain other groups who should at that point also receive priority. People, say, with learning disability and autism, certain key public service workers, teachers, the police, they will all have to be factored in that post 15th of February prioritisation decision as well.
Indeed. But as the person running the NHS, from the NHS perspective on that, in terms of reducing pressure on hospitals, it would be to vaccinate those people that are being admitted to hospital with COVID in those age groups in the 60s and 50s, rather than, there might be other reasons to vaccinate them, but from an NHS point of view, not so much healthy professionals who are working in other areas.
Purely from the point of view of reducing the number of hospital beds occupied by patients with coronavirus, that's right, but that's not the only consideration that policymakers legitimately would want to take into account, which is why I think teachers and police and other key public service workers, that will be one of the discussions that will need to be had. I mean, to state the obvious, fundamentally, the most important thing is just to get the overall infection rate down, in that this is not principally about pressure on the NHS, this is principally about reducing the avoidable death rate, and it is excess infections that give rise to excess deaths.
Indeed, but certainly reducing deaths, but also protecting the NHS. It's part of the slogan, it's part of the phrase. This has been an important imperative, so it is important to know what would help achieve that. But thank you very much indeed.
That's right. Although just on that particular phrase, I mean, as we've discussed, some of us discussed before, I mean, I think seen from the point of view of staff across the health service, it's not so much protecting the NHS, it's protecting the NHS's ability to look after the full range of patients. And so where you have coronavirus out of control, then obviously that does begin to disrupt other care. And as I've written to the Health Committee, that's been the experience in many other European countries over the course of the pandemic. You know, we've seen that in France, we've seen that in Germany, Netherlands, Switzerland, Belgium, the United States. This is Japan right now. So look, I mean, this is a international phenomenon. This is not some distinctive feature of the UK or the NHS that when you have coronavirus out of control, it disrupts other care.
Absolutely. Thank you very much, Simon.
Thank you. Sarah Owen and then Rosie Cooper.
Thank you, Chair, and thank you, Sir Simon. The success of any vaccine rollout depends on take-up by the majority of people, and research presented to SAGE found that worryingly just 28% of Black, Asian, minority ethnic people intended to be vaccinated, compared with 85% of white British people. Are you aware of any such issues, and how are you ensuring that take-up is high among people from higher risk groups? And how are you collecting that data, and have you got any information that you can share with us today?
Yes, well, thank you. That's an incredibly important point that you raise, and it is a genuine and deep concern, because we are seeing more vaccine hesitancy on the part of some groups in the population. Overall, at this point, I have to say, given the targeting at the moment on people aged over 80 and over 75 and so on, actually take-up has been in the round fantastic. So we're seeing a very strong response. When we originally put forward the vaccination strategy, we hypothesized that population take-up might be something like 75%. We're obviously at 80% already in the over 80s. Over half of people aged 75 to 79 have now had their first vaccination. So actually uptake is going very well. But as you say, there are a combination of access, systematic efforts to misinform and lie about the vaccination program, targeted particularly at minority populations, and in some cases, long-standing mistrust of public services, which are standing in the way of people coming forward. So there are a whole range of things that are being done to try and ensure that that doesn't stand in the way of equitable uptake in the vaccine. The NHS will be fairly offering it to everybody, but we want to make sure that we don't have distortions in uptake. The first thing, of course, is tracking data. So those uptake figures are, while protecting, of course, people's confidentiality, at a small area level, being shared now with local authority directors of public health, so they can do the great work which they are well known for, engaging with local communities, with faith leaders, community groups and others to encourage uptake. Secondly, targeted action to address misinformation using communication channels and people who are trusted in different communities. And then thirdly, over and above that, making sure that the places where vaccination can be given are sufficiently accessible and diverse, that they don't stand in the way of uptake as well. So a lot of work both nationally and locally involving public health directors, local authorities, faith groups, community leaders, and the whole of government as well.
Thank you, Sir Simon. So do you collect data on ethnicity for vaccine take-up, just to confirm that?
Yes.
Yeah, okay. And another question that I had around vaccine take-up is about, we have lots of overseas workers in the NHS, and we've seen some worrying reports that unless you have a vaccine, unless you have an NHS number, you won't be eligible for a vaccine. Now, that would discount many overseas Black, Asian, minority ethnic workers in the NHS.
Fortunately, that's not true. Completely untrue.
Thank you. Thank you for confirming that. And how are you planning to reach those with no recourse to public funds for the vaccination programme?
We are going to be doing outreach. Are you talking about for people without a permanent address, homeless people, travellers, other groups?
And migrants.
Migrants, yes. Well, that's why we are working with Directors of Public Health. It's not the case that you have to be on the electoral register or anything like that in order to be invited. And as we move through each successive cohort, there will come a moment when we will say, if you haven't been contacted, then please come forward yourselves. Right now, because we have been asked to move down the risk pyramid, the NHS is asking people to come and book an appointment. So we're saying, wait for us to contact you rather than you phone your surgery, for example. But as we get to the end of each cohort, we will then be saying very clearly, if you fall into this category and you haven't been vaccinated, then here's how you can come forward and be vaccinated, alongside the community outreach that I just described.
Thanks.
Rosie Cooper.
Thank you, Chairman. Simon, good morning. Could you explain to people how they will know when they're getting the second vaccine? And I don't just mean by date. If we're going to meet what I presume is the Prime Minister's target of 14th of February, when do those people get their second vaccines?
So the target is that everybody in the first 4 categories should have been offered their first vaccine dose by the 15th of February, offered and had the opportunity to have it, I should say. And then the second doses will follow within 12 weeks of whenever the first dose occurred. So what many, if not most, of the vaccination services are now doing is, at the point somebody has their first vaccination, they may be being given a little card with a date on it, which says this is when you will come back for your second vaccine. But in the case of those people whose appointment had to be rescheduled, then they will get a call from whoever it was gave them their first vaccine.
Absolutely. So are you able to say, because most places, hospitals, doctor surgeries don't know when they're getting their vaccines, they don't know when it's due, the supply seems to be intermittent. How can you be sure that you're going to be able to meet all that?
We are at the moment pretty much using up each week's vaccine as we get it. As we receive it through the safety testing, the batch testing and distribution to the NHS, then it gets sent out across the country. We're wanting to do it in a fair way so that each part of the country has enough vaccine to have been able to offer all of their 70-year-olds and above and their high-risk patients and their staff that first vaccine, which is why for the time being we're on this so-called push model for fairness. But what we will then do, to your question, Rosie, is for the second doses, we will be partly moving on to a so-called pull model, where the local services will be saying, I need this many vaccines next week for my second vaccinations, and then the vaccination team will make those vaccines available to them.
Okay, Simon, I've got many constituents, including staff at Southport Normskirk Hospital, who've caught COVID more than 3 weeks after their first vaccine. And I know the government's doing a communication push on that. But do you think it's misleading for the Prime Minister and ministers? And I've heard it this morning on this committee. People keep referring to the number of people vaccinated, not the number of people who've received their first vaccination. That is misleading.
Well, I think as long as we're all clear what we're talking about. So I think I've tried to be personally quite clear on that point. I mean, the good news is that based on the data that the MHRA and the Joint Committee on Vaccinations and Immunisations and the Chief Medical Officers and Jonathan Van Tam, the Deputy Chief Medical Officer, have put before us and published, actually the protection you get after your first jab appears to be very significant. But clearly, the recommendation, and which the NHS will deliver on, is that people will get a second booster jab as well. So,
but not within the stated 21 days. I spoke to Pfizer and they're clear, they're not happy.
Well, look, that has been a well discussed topic indeed. I think yesterday the chair of the JCVI, the virologists, the clinicians who led that recommendation together with Jonathan Van Tam over the weekend explained their reasoning just in very personal terms, and I know they won't mind me saying so, but look, my parents are both in their 80s. If it were my choice, which it wasn't because this was obviously an expert recommendation to government, but if it was a choice of one of my parents having 2 jabs or both of them getting their first jab, I would far rather both of them had their first jab, which is fortunately what has now happened. So there is a good logic to that, but clearly the evidence needs to be kept under continual review.
Thank you.
Zara Sultana.
Thank you, Chair. I'm going to carry on with the line of argument that Rosie was making, because for the Pfizer vaccine, the studied and approved interval is 21 days between the first and second dose. For the Moderna vaccine, it's 28 days. And for the AstraZeneca vaccine, the trial is for 2 doses, 28 days apart. Within the NHS, we've seen staff illness rates higher than usual and confidence within the profession badly affected. So what evidence is there to reassure NHS staff that they are adequately protected after a single dose of the vaccine?
Well, I think perhaps what I might do is just quote Professor Anthony Harden from the Joint Committee of Vaccinations and Immunisations, who's well placed to answer that precise question. And this is what he said earlier in the week. He said, "We examined the data from the Pfizer study and concluded that there was really no substantial evidence that a second dose gave substantially longer and better protection. Pfizer technology is the same as Moderna, which is this messenger RNA type vaccine, as you know, and the latter, i.e. Moderna, recently submitted a document that shows 90% efficacy even after 2 months from just 1 dose. So we think this is the right public health decision, but it's difficult to communicate."
Thank you for that. Preliminary data from 200,000 people vaccinated in Israel shows that a single dose of the Pfizer vaccine may provide less protection than originally hoped. Their study shows that the effectiveness of the vaccine after 1 dose is actually as low as 33% rather than the 89% initially suggested. So I and others would argue that the government's vaccination strategy is clearly rooted in overcoming supply shortages and meeting that target of 15 million by the 15th of February. But could this be doing more harm than good based on the data that is coming from Israel?
Well, I think when that point was put to Professor Harden, what he said was, our clear steer is that 1 dose with a delayed secondary dose is going to save many more lives nationally. And I think you will have seen that the Israeli Ministry of Health has clarified the figure that you refer to as unlikely to be accurate. But look, these things need to be continually kept under review. But your key point, I think, was, is this being done because of a supply shortage? And the answer to that is, of course, yes. There is a supply shortage. If there were unlimited vaccines, then you wouldn't see what the European Commission were saying yesterday. You wouldn't see Italy attempting to sue one of the manufacturers. You wouldn't see Germany in uproar as it is today. So, of course, there's a supply shortage. And we've done very well in this country to get the supply we have available to us. The question is, how do we use it to best effect?
Thank you. You mentioned having the data constantly reviewed. Is the NHS and the government committing to an independent scientific review of the data?
Yes, well, I mean, the MHRA is independent of the NHS and of government, and the data, the trial data on which they base their decisions have also been published in peer-reviewed journals.
My final question is just around the language around vaccinations. We are hearing from government ministers and others referring to people who've only had 1 dose as vaccinated. There's a risk that people think that they're protected against the virus and they will let down their guard. And of course, this affects public health as a whole. Has this risk been considered in terms of the language that is being used?
I think it has, and I think you're right to raise the point. I think Jonathan Van Tam wrote in one of the Sunday newspapers very clearly on this point on Sunday, which was then widely picked up. So I think, there are 2 issues here, aren't there? The first is that within 12, 14 days of having been vaccinated, your immune response and perhaps your T-cell response has not kicked in sufficiently that you're not getting that that you would expect. And the second point, of course, is that people will need their second doses in order to get the full benefit. And there's an unknown, which is the extent to which, having been vaccinated, that as well as protecting you as an individual, also reduces your chance of passing on the virus to other people, the transmission effect. And obviously understanding those data will be very important as they become available, not just in this country, but internationally.
Thank you.
Thank you. James Davis, finally, on the vaccine rollout.
Thank you, Chair. So Simon, from March, there will be large numbers of individuals coming forward for their second dose of vaccine. Are you expecting that to slow down the rollout of the first dose to the remaining groups 5 to 9?
Well, we're going to have to. I mean, you're right to make the point. First and foremost, those second doses have got to be delivered. So, you know, we look 12 weeks on from when the first doses were delivered, and we know that that has to be first call on the vaccine available in those weeks. Over and above that, then, as we get increasing clarity as to what the available supply will be, that will shape the speed at which we can advance into those other groups. I mean, my expectation is that we will sort of do two things simultaneously as we move our way into working age adults more broadly. The first is that if we've got a lot more supply, or rather when we've got a lot more supply, then we will be able to make vaccine available in many different outlets, as it were. So lots of high street pharmacists will be able to offer vaccine, because there won't be such an issue about having sort of inventory held rather than injected. And at the same time, the larger vaccination centres that we've established will be going all guns blazes for increasing numbers of people. But right now, supply is constrained, and we've got, you know, over 1,000 GP-led primary care networks who are doing vaccinating. We've got over 250 hospital sites that are doing vaccinating. We've got pharmacy services coming online, and we've got 49 larger vaccination centres. So, you know, we'll want to give people choice, and we'll want to combine accessibility with scale as supply increases.
Very good. And considering supply, there have, of course, been bonus doses that have been obtained from vials. So in the case of Pfizer, 6 doses from a 1.8 ml vial. And in the case of AstraZeneca Oxford vaccine, I think 11 and 9 doses from vials otherwise designed to contain 10 and 8. Do you have any data on the extent of success in terms of obtaining these extra doses?
Yes, well, I think the first thing to say, of course, is that we were the first people to spot the fact that that was possible, given we were the first country to be using Pfizer in that way. And so generally, in most batches, vaccinators have been able to get 6 doses rather than 5, not in every batch, I might add. And this is partly because of the prescience of our supply team in ordering the right kind of needle that has a special little rubber stopper that means that all of the vaccine goes out of the end of the needle rather than any being left in each vaccine, in each administration unit. So that has clearly helped, and the same is true with AstraZeneca, and I think Pfizer either have or will change the formal authorization to identify 6 doses as the expected yield for each vial.
Okay, and finally from me, what is your working assumption as to the return of the NHS to normal operation, bearing in mind yes, vaccines are being deployed, but the risk of waning immunity, the risk of new strains. How do you see the coming year or so?
I mean, obviously, there's a big cone of uncertainty there, but I would say the first half of the year is probably mainly going to be a story of vaccine rollout. And I think the promising feature of the new vaccine technologies that are being deployed, in particular the messenger RNA, is that BioNTech and others have said that it's relatively quick to repurpose if a further booster is required for a different strain. I think the head of BioNTech was talking about maybe a 6-week turnaround, and then you've obviously got to do the authorization and look at the data and so forth. But nevertheless, you know, that's a huge turnaround. I mean, I think until COVID vaccines, I mean, one of the fastest developments of human vaccines had been mumps in the 1960s, which have taken 4 years. So look, this is, I mean, we're just you know, in a completely different place thanks to brilliant science here. But I think the first half of the year, vaccination is going to be crucial. I think a lot of us in the health service are increasingly hopeful that the second half of the year and beyond, we will also see more therapeutics. We will see more treatments for coronavirus. The ones that have already surfaced are well known, the corticosteroids, dexamethasone, the repurposed arthritis drugs, but there are a number of others in the pipeline. And I think it's possible that over the course of the next sort of 6 to 18 months, coronavirus also becomes a much more treatable disease with antivirals and other therapies, which alongside the vaccination program obviously holds out the hope of a return to a much more normal future.
Thank you.
Thank you very much indeed. Now for the final part of this morning's questions, we want to focus on some longer term reforms that may be sensible given the experience we've been through with the pandemic. And I want to start, if I may, Sir Simon, with the question of workforce, because there's been so much discussion throughout the pandemic of the pressures on the NHS and social care workforce. And the 10-year plan was published 3 years ago, but the Treasury still won't allow the NHS to publish its own projections of the numbers of doctors and nurses you think you're going to need over that 10-year period. So we just have no idea if we're actually training enough. Now, obviously, there's been a lot of extra people brought in during the pandemic, but would a long-term solution to this perennial question of whether we're really training enough doctors, nurses, endoscopists, oncologists, so on, be for a body, an independent body like the ONS, to work with NHS England and every year to publish the long-term workforce requirements of the NHS so we really can make sure that we're training enough people?
Well, I think there's great merit in what you suggest, Chair. I think the paradox is that fortunately the health service does have a medium-term outlook on its revenue funding, its day-to-day funding, but sometimes the outlook for workforce training and indeed for capital investment in infrastructure has tended to be more short-term. And of course, those are things where the planning horizon is much, much longer. So anything that can bring predictability to those decisions, both investing in people and investing in infrastructure, I think would be strongly welcome. Now, as it happens, I think there are some very positive signs on the workforce front, particularly nursing. We've seen strong growth in the number of young people inspired to enter undergraduate nursing. We've seen significant reductions in nurse vacancies over the course of the last year, and we're up 13,000 whole-time equivalent nurses as well. So I think we're on track for the goal of 50,000 more nurses net by which is one of the government's manifesto commitments as it happens. But my view looking out over the decade is that whereas, say over the last 5 years, we've seen an increase of nursing of about 25,000 whole-time equivalents, and we're looking at 50,000 by comparison over the next equivalent period. I think we're going to need significantly in excess of 100,000 more nurses over the course of the next 10 years. And so, keeping that focus and matching that with the actions that are needed makes a lot of sense.
Thank you. Laura Trott.
Thank you. So Simon, obviously to deal with this pandemic, you've had to redeploy a huge number of staff from their jobs elsewhere in the NHS. Have there been any barriers you've encountered in trying to do this?
Generally, no, in that people have, under the most difficult circumstances, just all pitched in with incredible esprit de corps, while recognising, frankly, that people are tired and stressed and frustrated, I would say, across the health service. If I'm speaking very frankly, look, it's this coming Sunday is a year since the first group of people were repatriated to this country, if you remember, from Wuhan to the Arrow Park Hospital in the nursing accommodation. And this has been an incredibly intense and difficult year for most staff across the health service, and indeed for families and the country as a whole. But have people chipped in? Have people responded incredibly flexibly? Yes, they have. We've got medical students helping out. We've got nursing students helping out. We've got consultants from other disciplines helping out on the acute medicine ward. We've got therapists. We've got nurses flexibly supporting their colleagues in critical care. And so the silver lining to this, if one can even allow oneself that phrase, I think, is that what it has shown is that under these circumstances, health service staff will always go the extra mile, but that is not a sustainable basis on which to either think about the future of the pandemic or indeed the future of the health service.
Absolutely right. I guess when we're thinking about making recommendations as a committee in terms of how we can change things in the future to help prepare ourselves better for future pandemics, I guess the exam question is, do we want to make any changes in terms of contracts, in terms of the specificity, in terms of emergency for staff? Is there anything in and around that area that you think we should be looking at or recommending?
Well, I think two or three things perhaps that get to your question, Laura. One is that often in healthcare, people make a career choice about which specialty or discipline they're going to enter, and they might make that choice in their 20s. And then in effect, their 30s, their 40s, their 50s, their 60s, they spend the next 30 or 35 years working in that area. What this force majeure has brought about is a lot of people adding something else to their clinical practice and their experience. And that's not to say that that is should be a permanent part of people's future careers. But I've talked to a number of staff who actually have quite feel that it has been a professionally important thing to also have an adjunct discipline, if you like. So there's a sort of reservist idea, not of people out of the workforce, but a sort of reservist supporting critical care, even though actually my fundamental professional endeavours are going to be in a different area. And there's also a question about people wanting to change disciplines mid-career. It's quite hard to do that, actually. You sometimes find people moving out of, say, hospital medicine into general practice, and sometimes, well, less so vice versa in medicine. But I think finding ways for people mid-career to switch specialties or subspecialties is also quite important for personal development and for the flexibility of the health service.
Thank you.
Thank you. So Simon, when you arrived as Chief Executive, you persuaded me of the need for a 5-year plan. And then in the spring of 2018, we both fought very hard to secure a 10-year plan for the NHS, which I think has been an important way of allowing long-term planning. But in the pandemic, there's been a lot of discussion about the lack of resilience in the social care system. Do you think the social care system too needs a 10-year plan?
I definitely do. In fact, I think both the committee and you, Chair, have made that point, and I said the same last July when it was the 72nd anniversary of the National Health Service. I said, given all of the pressures and the tragedy that we've seen in the social care sector through the pandemic, one fitting legacy of that would actually be, for once and for all, to resolve this question about fair funding and reform of adult social care. Now, it's easy to say that. I think the question then is, what are some of the sort of judgments and trade-offs that are needed in order to make a reality of that? I think you, the Health Committee, you published a report on the 22nd of October that identified a requirement for additional funding by 23-24, which, in some senses is a significant sum, but relative to some of the emergency expenditure that's occurred during the course of the pandemic, actually looks incredibly modest. I mean, I think what you were proposing as the requirement for adult social care in 23-24 is less than a third of what is budgeted to spend on the test and trace program this year, for example. So, I think where there's a will, there's a way, but there are a number of interesting and important trade-offs that have got to be thought about. The first is, for any extra public funding going into social care, what proportion of that should be used to make the current financial burdens fairer in other words, to make things that people are currently paying for free, versus what proportion of that extra public funding should go to meet unmet need, to actually buy more social care. And obviously buying more social care is a crucial part of having dignified support in old age. There's a set of judgments to be made around not just supporting care homes, but giving people wider flexible options, including housing with support, so that as people's needs change, they're not necessarily having to move where they are living. Adult directors of social care rightly remind us that support for older people is perhaps only half of the budgets that they're responsible for adult social care. Actually, people with learning disabilities and autism, mental health, physical disabilities, those are also a big part of social care, and they need proper attention too. And then on provider resilience, I think part of the committee's recommendations were around increasing support to shore up the structure of current provision. And again, we've got a very plural set of providers in social care, and I think we've got to be quite thoughtful about what are the needs of a small, socially driven care home versus one of the larger private equity-backed chains out of the Cayman Islands. You know, so in other words, I don't think this can. It's not a question of there being a sort of pre-baked recipe, but on the other hand, the shape of what a sensible outcome would look like has been well debated down the decades, and I do think it is possible to get there.
Thank you. Barbara Keeley.
Thank you, Chair. Can I first say I want to put forward my admiration for the work done by the NHS staff and the extent to which, as you said, they've gone the extra mile for Simon. So my questions are set in that context, but there are some issues, particularly around how the NHS and social care and carers work. The first is just an issue around hospital discharge guidance, the discharge to assess model. This makes no mention at all of family carers, no mention of carers assessments, which is a right, no discussion of a person's willingness or ability to care. And that is a major omission in that policy, and it's causing deep concern. So can you comment on that and whether the guidance should be reissued, inserting that missing detail?
Yeah, I'm certainly happy, Barbara, to raise that with the team. I know they've been working closely with Age UK and a number of other groups as well on this, but I think those all sound very sensible points, very fair.
Okay, thank you. Now on to just back to questions about vaccines, but this time about prioritisation. Despite the JCVI identifying unpaid carers as a priority for vaccines in Group 6, the vaccines delivery plan does not mention carers at all in Priority 6, and carers are concerned about it. Can you comment, and should the vaccine delivery plan now be updated? And the other sort of key issue is how will those carers be identified, as the NHS records may not reflect their caring role? There's some good practice among GPs sometimes to identify carers, but it's certainly not across the board. So how will that aspect of those carers getting their vaccines work?
Yes, well, thank you. As you say, JCVI did reference the important role of carers, and I think once we have got to mid-February and hopefully the first 4 groups have had their offer of first vaccination, then there will be a need to take stock on what the next phase of the vaccine programme looks like. And I think you're quite right to raise the important role and needs of carers, and I will make sure that that is taken account of by the JCVI when they put forward their next set of recommendations.
Okay, I mean, I
can't obviously speak for what they say, but I will make sure that they hear the point.
Oh, thank you. I mean, I think this is part of the difficulty in that in the end, I think if carers are not mentioned in guidance, if carers are not mentioned in vaccine priorities, they just feel that they're, beavering away, providing that care they're providing, which we all rely on in the same ways we rely on your NHS staff, and that nobody cares about it. So a final point about vaccines again is a real concern about whether home care staff are being vaccinated. Hospital vaccination hubs are meant to work with local authorities to identify those care staff but I'm hearing the communication with care providers is patchy or even absent. I understand this is difficult because you've talked about the plurality of the type of providers that are out there, but if care staff are not being reached, that's an issue. So my question is, what can be done to ensure that communication improves from hospital hubs so that they can identify those care workers out in the community and invite them in for vaccination?
Yeah, so I think the Department of Health and Social Care are writing to care providers to clarify exactly the points you raise. Principally, the responsibility for identifying those care providers rests with local authorities and working with their care providers in their local area, and then they make available those staff, the employers make available those staff to be vaccinated to the hospital hubs or the vaccination centres or wherever it may be. I mean, the reality is the hospital hub or the vaccination centre won't know who all of those people are. The people who will be the care providers and the local authorities. So local authorities have been assigned that role by the Department of Health to
I understand that. Sorry, I did say that in the preamble. The point is, though, what we're hearing to some extent is it's not working. That communication from the hospital hubs to the care staff is not working. It's patchy in some places, and in some places it's absent. So there's a serious thing there about care staff not being vaccinated.
Okay, but just to be clear, I don't think the hospital hubs are not in a position to directly communicate to a care assistant. They wouldn't know who it's the.
I understand.
The agency, it's the care provider, the local authority. They generate the names and the appointment, book them into appointment slots, and then the NHS does the actual vaccinating.
So if we can feed into the process that in some places it's not working all that well, and perhaps just improve the communication, I think that's the key thing. Thank you.
Thank you. Now I just want to talk about, if I may, another aspect of the pandemic, which has been the very unequal impact on different groups within the population. And I just wonder, should the levelling up agenda be expanded to cover health inequalities so that disadvantaged groups, people from minority ethnic backgrounds, people from deprived communities, the clinically obese, and so on, are less exposed and at risk in a future pandemic?
Yes.
Well, that is very clear. Okay, thank you. Let me just bring in Sarah Owen on that point.
Thank you. Just to dig a little bit deeper into that, the mortality rate from the virus is in deprived areas compared to more well-off areas is double that. And so as well as having the levelling up agenda extended into health, is there one other thing that can be done to mitigate this huge health inequality that we're seeing, particularly as the financial impact of COVID will be felt for the coming years?
Yes, well, look, I think you're right in what you say. I mean, there's a nexus of social explanation that explains why there is that higher mortality rate. Generally speaking, it's not because of differences in treatment, but it is because of differences in the infection rate and the prior circumstances that mean some people are then more likely to die as a consequence. So, for example, if you've got diabetes, both type 1 and type 2, you're at much elevated risk of dying if you contract COVID. So a combination of occupational exposures, crowded housing, prior health risk, including obesity, as the chair has said, broader inequality, that has all compounded to create that differential that you describe. Race and ethnicity also, I think, is an independent explanation over and above those other variables as well. And so not just as part of the response to COVID, but as a catalyzing need for change, I think it is a very powerful reminder that levelling up in the way that the chair described and you described, Sarah, needs to take place.
Thank you. And just a final one from me in terms of long-term lessons. What has the pandemic taught us about the right balance of doing things locally and doing things centrally? So, for example, on test and trace, there's been much criticism of a top-down approach, but on vaccines, we seem to have a command and control system that's worked pretty well. I just wonder what you've learned in the pandemic about how to get that balance right.
Well, I wouldn't quite characterize the vaccine program like that, actually, Chair. What I would say is that we have thought very carefully, and look, this is still a work in progress, and we're still in the early stages of the vaccination program, so it's too early to draw definitive conclusions. But we thought very carefully about the things that need to be done nationally and the things that need to be done on a highly localized and distributed basis. And so clearly, procuring vaccines, vaccine supply, that's not something that you distribute. Indeed, that's been done on a UK-wide basis. But on the other hand, rather than creating a national vertical standalone vaccination program, the judgment I took was that we've actually got groups of GPs and pharmacists and others who actually have got a fantastic track record of vaccination and indeed vaccinating the right people at the right time. Because of the particular handling properties of the Pfizer-BioNTech vaccine, actually, we couldn't have just distributed that to all 7,000 GP practices or 9,000 pharmacies in England and said, off you go. But we had created these primary care networks as part of the long-term plan, about 1,200–1,300 of them, which exactly the right population level to organise a locally sensitive vaccination campaign. And so supplies nationally, fair distribution across the country, local mobilisation, including of volunteers, whether that's the St John's Ambulance, the use of premises that lots of organisations, including local authorities, have put in, but with our primary care network as the building block of that, where 3/4 of vaccinations so far have been delivered through those local vaccination services led by primary care. That I think has so far proven to be the right combination. So it's not either a central or a local. It's figuring out which things need to be done nationally and which things need to be done regionally or locally.
Thank you, Luke Evans.
Thank you, Chair, and thank you, Sir Simon. I'm interested in the red tape and bureaucracy culture coming down from the top. Time is short, so if you could answer this question. In your previous jobs, you've seen a lot of different systems. On a scale of 0 to 10, when you came into the NHS, 10 being the most efficient and no red tape, and 0 being all red tape, what was your assessment at that time when you came in? Just a simple number.
Well, there are various ways of answering that question, aren't there? One is to ask the nurse on a ward, the junior doctor, how much of your time is spent patient-facing caring, and what those staff, of course, say is that actually a proportion of their working week is spent on data entry, medical records, and all the rest of it. So there's some of that. But by the way, that turns out to be an international phenomenon. That's not an NHS-specific phenomenon, I would say. And then on the overarching red tape, as it were, or our administrative costs, of course, they're very, very low. I mean, we spend about 2 pence on the pound on administration in this country compared to 5 pence and 6 pence in France and Germany, and way more than that across the Atlantic. So actually our on costs, if you like, are very, very low.
But the reason I ask this is because I'm keen from the vaccinator is a good example. Frontline, when the vaccination program was brought in, there was 14 different pieces of information that someone needed to sign up, including manual handling, spotting potential sort of terrorist threats. Very quickly, the NHS acted, scrapped all that, and made it more streamlined. So that's due to the necessity of the pandemic. Thinking as we're looking for the future, what do you try and do as the leader of the NHS to install that kind of rapid response for when we're in peacetime, effectively? Because clearly the NHS can change. What are you doing to give it the chance to change?
Yeah, no, I agree with the point you just made, actually, Luke. So, I mean, look, on those requirements, they were streamlined very quickly. We had a very productive, or the Department of Health had a very productive conversation with the Home Office and said, actually, these prevent terrorism requirements, maybe they don't need to apply in this situation. We had a very good dialogue very quickly with the Care Quality Commission around some of the requirements that they would normally have, with the medical royal colleges and so on and so forth. So look, absolutely. And I think that has been the experience experience, and it's been pretty well recorded now across the health service, that when people just focus on the goal and then everything else is just a means to the end, and if it's not contributing, then you get rid of it. That is absolutely the essence that we want to continue with.
And how are you going to keep that spirit up?
Well, because I think that has turned out to be the sort of fuel in the tank of driving clinical change in all kinds of ways across the service, and people can see it's working and they want to sustain it. So, you know, when it comes to setting up home-based services, monitoring with pulse oximetry, oxygen. I mean, that's clinicians who have seen that, have had the ability to get on and innovate and then spread that across the service. When it comes to establishing new clinics for long COVID, say, where we've got over 60 and more opening, that began with clinicians in places like Leicester and Newcastle and University College hospitals, identifying a problem, doing something about it. We then got NICE in to say, all right, what does this need to look like in a more standardized fashion? So that's the change model, and I think we want more of it.
So I'm really keen to hear that, because you, as the leader of the NHS at the moment, are going to come into the contact with almost the entire population of the UK for 15 minutes when they come in and have their jab. What plans are set in place to get opportunistic public health interventions like stopping smoking, obesity into those big centres? Because this is the one time that you may be able to contact people the NHS has never, ever been able to have contact with.
Yeah, that's a great point, actually, Luke. And obviously, just to clarify, the 15-minute wait is particularly for the Pfizer-BioNTech vaccine rather than for the Oxford-AstraZeneca vaccine. And I think that's an interesting observation, and I will put that to my colleagues and see what they come up with. But if you've got ideas in the meantime, please do so. I know that GPs locally, exactly in the spirit of this conversation, are themselves already taking this opportunity. And, frankly, down the line, I would hope that not only other opportunistic contact, as you described, but it would be great if COVID vaccine and flu vaccine ends up being combined into a single vaccine, which we might see for, if not this winter, then future winters as well. So I think there's a lot of opportunity.
That's really great. And I guess it's in the spirit of thinking what we can do better in the future when we do with it. And yeah. I don't expect you to give answers to us on this, but maybe just a commitment to the committee that you'd be happy to submit a plan towards us about how you are thinking about the big picture from the future of the best ideas that we can take forward would be very welcome.
Sure. And if in the meantime, if you have got particular ideas or the committee's got particular ideas on that as well, then I'd love to hear them, definitely.
Thank you very much, Chair.
Thank you. Neil Hanvey.
Thank you very much, Chair. Thank you, Sir Stephen. Sir Simon, sorry. Can I first go back to cancer therapy and ask about the cancer recovery plan, which was released on the 14th of December, but the work on that will have been done at a time when we didn't really expect the situation to escalate in the way that it has since it was published. You mentioned earlier that it was really over the Christmas break that we realized that things were beginning to get challenging. And given that there's quite a short timescale for the cancer plan and it was worked up when we didn't expect things to be as challenging as they are, is there a fundamental need to revisit that and to consider the recovery of cancer treatment in the long term?
I don't think so, no, in as much as I think the sort of various themes and actions that were set out in the plan are the right actions. As you say, though, we're in a much more challenging circumstances relative to coronavirus than was envisaged when it was written. But are those things that are in that cancer recovery plan the right things to do as soon as we're able to the maximum extent? I think they are. And as you know, we developed them with our partners in the cancer charities, Cancer Research UK, Macmillan, a number of others as well. So look, we're listening very hard to what they are telling us makes sense too. I mean, if it's of any solace, I suppose I can say that in terms of urgent referrals, they do appear to have been holding up. And this was obviously one of the big concerns in the first wave, that the number of people coming forward fell, which is why we've been sort of repeatedly asking people to help us help you by come forward to have that lump checked up if you're concerned, or if you've got chest pain for a heart problem. And so in the week ending the 3rd of January, the 2-week urgent referrals were actually above the same time, the volumes we had this time last year. And the most recent treatment data I've got suggests that we're at around the same level as we were the prior year. But look, you're right to raise it, and we need to just keep it very tightly under review.
Yeah, I mean, that's reassuring. I guess the key question is the short-termism of a March date, because we are, without any critical element to this statement, there's no way that the backlog in cancer treatment is going to be fixed by March. So I guess that's the key thing, is that a much longer term look at how that's going to be recovered. And organizations like Macmillan and others have already identified that there is a shortage as it currently stands in the cancer workforce. So I think it's just important to emphasize that. I want to move on now to test and trace, and the third component of that, isolate. And at the moment, as I understand it, 45 billion has been allocated to that endeavour, and a large component of that is innovative lateral flow tests. And even the government's own evidence from the Liverpool data shows that there's somewhere around a coin flip of reliability on the in-field testing rather than controlled environment of a lab. And I just wondered if you felt that, given that the whole point of that is to understand community transmission, but we also know that less than a third of people who should be isolating are doing so, and that will have a consequence in community transmission. Do you feel that there could be other ways to utilize that that significant amount of money in a more helpful way?
Well, look, I can't comment specifically on test and trace because, as you know, that is run by the Department of Health and Social Care rather than by the NHS or NHS England per se. What I would say is that lateral flow testing as a way of helping keep NHS staff safe has actually been an important development. Once there were sufficient lateral flow tests that test and trace were able to make them available to us, we've made those available to our frontline staff. And with sequential testing, twice a week in the case of NHS staff, that provides improved sensitivity and specificity that deals with, I think, some of the concerns that were raised as a sort of one-off community screening methodology. But look, I mean, to state the obvious, for test, trace and isolate to succeed, it has to overcome at least two obstacles in any country. First of all, the third bit is crucial. People actually have to isolate. And the other point is that given the high proportion of infections that are asymptomatic, you can't just rely on the front end being filled by symptomatic presentations of people wanting to get tested. So you've got to deal with those two things. You've got to deal with the asymptomatic element to it, and you've got to deal with the isolate element to it. And that's true in any country.
Okay, I've used up my time. Thank you very much, Sir Simon.
Thank you very much, Neil. Over to Taiwo next.
Thank you, Chair, and thank you, Sir Simon. My questions will be around core non-coronavirus essential services. In the first lockdown, we saw a decrease in the amount of patients presenting to A&E with heart attacks, and that's the same with the amount of patients who have been admitted on hospital wards. So what is being done to ensure that heart services are given the level of priority needed during this wave of the pandemic and beyond?
Yeah, well, you're quite right about that. And so even during April, the health service unusually began, directly communicating, advertising for people to please come forward for emergency care. And we've carried on doing that as part of the Help Us, Help You campaign. As I think I may have mentioned earlier, this has been a problem in a lot of countries. So we saw in France reductions in out of hospital cardiac arrest patients are presenting. The same is true in Germany and Italy and so forth. So what we've been doing is our level best to make sure that people get the message that if you're experiencing these symptoms, please dial 999 or come to hospital to be looked after.
And that's really important because many patients are still being cautious as to whether or not they are able to go to the NHS with these kind of healthcare conditions. I just want to quickly move on to elective surgeries. Now, in August 2019, there were about 660,000 patients waiting more than 18 weeks for an elective procedure. Now, that number tripled in August 2020. So what is the current estimate of patients waiting for elective surgery, and what is being done to reduce the number of patients waiting?
Well, the knock-on consequence of having a third of our hospital beds full of severely ill coronavirus patients who need looking after is that obviously hospitals have been able to do much less routine, non-urgent operating. So the key to getting back on track is going to be first and foremost getting coronavirus occupancy coming down. Secondly, it's going to be continuing with partnerships where that is needed, as it will be, I think, with other providers. And thirdly, we've got to look at the new model of diagnostic care, because we've got an opportunity following a report that Sir Mike Richards did, which I commissioned, to really change the way in which people get their tests done right at the start of their elective care pathway, their scans or their lab tests. And so we're investing specifically in standalone diagnostic centres over the course of the next 12 months, so that you don't always have to be routed through your GP to a hospital to get the test, so you can get started on your elective care pathway. A very high proportion of people who are in that overall waiting period are actually waiting for their diagnostics.
Mm-hmm. From my understanding, the government has allocated £1 billion to support the NHS in managing the elective backlog. Do you believe that this will be sufficient?
Well, I think we don't know at this point what the total shape of the backlog will look like, because we're still, knee deep in the current wave of, well, more than knee deep actually. So I think that's a judgment that we're going to have to make spring, summer, and it will require not just money, but obviously we've got a constraint in terms of the number of surgeons and anaesthetists, as I've discussed. So everybody can see that is crucially important, but I think there are some other unmet needs that we're going to need to take seriously as well. I've mentioned mental health and the exacerbation that we will have seen in mental health needs. I've mentioned long COVID and some of these other conditions that a proportion of patients are continuing to experience many weeks after having had their initial coronavirus infection. So look, the shape of need in the health service will have changed as a result of the pandemic.
Thank you. Lastly, just quickly to ask about the dentist industry. The British Dental Association has criticised the new unit of dental activities target, which requires practices to achieve 45% of their pre-pandemic activities. Firstly, from your data, how many dental practices are currently being able to meet this UDA requirement, and how realistic is this requirement? And lastly, what support has been given to allow them to reach it? Thank you, Chair.
Yeah, so I think that's only a target for the last 3 months of the year. For the bulk of the financial year, practices have had the vast majority of their income protected. So in the round, dentists have, the government have provided dentists with significant financial support, as well as PPE and testing and so forth. But look, there's a difficult balance to be struck here. We've obviously got the urgent dental centres still going. There's a backlog of routine dental care that patients desperately need. There are constraints on what dentists can do given the aerosol generating procedures and the time gap between patients. So that was the judgment that the Department of Health came to for the last quarter of this year. But obviously that will have to be kept under review going into the new financial year as well.
Thank you.
Thank you. Zara Sultana.
Thank you, Chair. My question is about the impact of mental health. We know that the foreseeable future, we will have huge mental health implications for the population. This will particularly affect young people. What steps will the NHS take to meet the expected increase in demand for mental health services post-pandemic?
Thank you. Yes, you're right. So I think maybe three things to mention. The first is that we already were in the middle of quite a significant expansion of mental health services tied to the NHS long-term plan. And that has meant that actually for every year since 2015-16, investment in mental health has gone up faster than growth in the overall NHS budget. That's the first time in NHS history that's happened. That's independently audited. And so that has been helping address some of the long-standing service deficits in mental health care. So we need to carry on with the priorities that were identified there. And they range from, early intervention for people with psychosis, through to talking therapies, through to perinatal care, through to better mental health support in A&E departments, so-called liaison psychiatry for crisis care and so forth. That's the first thing. Second thing is, though, we've got to take a very hard look at the exacerbated mental health needs that have arisen through the pandemic, some of them which might be enduring and some of which might actually be somewhat one-off. So, proportion of people who report being depressed, for example, increased this summer compared to last summer. It's not completely clear to the epidemiologists whether that will still be the case next summer and the summer after. Fortunately, the predictions that some had that the pandemic might lead to an increase in deaths by suicide seems not to be happening in most countries, including this one. But as I said earlier, in other areas, such as young people's mental health services and eating disorders, urgent referrals really are going up very, very sharply. So the second thing we need to do is, over and above what we were going to be doing anyway, make sure we've taken account of those new needs. And then the third thing we need to do is underpin all of that with expansion of the mental health workforce. And this goes back to the Chair's question right at the start, in that if we haven't got the therapists, the mental health nurses, the psychiatrists, then all of the rest will be for the birds.
Thank you. Just a quick follow-up question. In England in particular, the Centre for Mental Health has predicted that 10 million people, that's almost a fifth of the population, will need mental health support, and 1.5 million of those expected to be children and young people under the age of 18. I was wondering what your thoughts were on the suggestion that there should be a counsellor in every school in the country to provide that mental health support for young people.
Yes. So as you know, I think probably at the moment between a fifth and a quarter of schools are working with their local NHS mental health services to beef up the young people's mental health support in school settings, to see whether, if doing that, not only provides better support for young people, but also reduces the number of specialist referrals into children and adolescent mental health teams. And the hypothesis is that if you can go upstream and get that support there, then that will have the downstream benefit. But that's still being worked through. And I think there's a very strong desire in mental health to make sure that any form of extra support has got a strong evidence base and actually is shown to have an impact on diagnosable mental health conditions. And so making sure that there's fidelity to evidence-based models rather than just doing things that might seem like they're going to be good, but may not actually have much impact. Very important to get that right as well.
Thank you. And my final question is just about the support being given to NHS staff at the moment, who are currently going through immense pressure and stress and trauma in many cases. What provisions are there for staff to get mental health support?
I think my colleague Perina Issar, who's the NHS Chief People Officer, has written to the Health Social Care Committee and has laid out a range of the supports that are available. We've put in place specialist mental health support for NHS staff, as well as other ways of getting psychological support, helplines, local services as well. But I think this is going to be something that's going to be with us for quite some time to come, quite frankly. And it's an area we are all very worried about.
Thank you.
Rosie Cooper.
Thank you, Chairman. Simon, generally, how do you think the community staff in the NHS are coping? Do you think that we're bringing a lot, and we all understand how difficult it is, bringing lots of staff into hospitals and leaving community undermanned, really? I've had a case in where a man didn't get a call back from community services. His family ended up calling 999 in essence, and then he ended up in hospital. He was palliative and he could have been cared for at home. He died in hospital. How do you think this pandemic is opening up the structural problems that the NHS has in the community?
Well, look, that's such a sort of broad set of concerns and considerations, isn't it? It's hard to sort of give a sort of glib response to that. So I think on community nursing and support for the clinically extremely vulnerable, including people on the shielded persons list, community health services have had to mobilise very significantly in order to do that, not only first time round, but then with the reintroduction of shielding recently. Fortunately, volunteers, not just friends and neighbours, but volunteers and indeed the role of local authorities through the LRS have played a big part in helping people at home. But community nursing, together with local pharmacists, have obviously had a big extension to the role that they've had to play in the light of that. And that's before all of the other needs that continue unabated and in some cases increased. So the concern again, as we look at conditions such as long COVID, is that there will be an increasing number of people who are going to need that ongoing type of support, not out of hospital clinics per se, but out of community health services. So my colleague Matthew Wynne, who leads our community health programme, is working very closely with the community health providers on exactly that.
Simon, I asked that question. It's a difficult question. I did appreciate how wide it was. But given that in the first wave of the pandemic, you paused reforming the NHS, and we're now in wave 3, which is substantially worse, much worse than wave 1, I'm getting an increasing mailbag about people who say they haven't had enough time to respond to the various consultations, just simply because of the pandemic and the effects it's had on them. And they believe that this is an attempt to implement structural change on the NHS, structural change on a battered workforce, and do it quietly while the pandemic is number one, in everyone's minds. How would you address that and reassure them?
Yeah, no, I'm not sure I think that's right at all, to tell the truth. I mean, I think what the pandemic has shown is the vital importance of different parts of the health service working together well, whether that's community nursing working with hospital teams, whether that's GPs working with each other and with pharmacists, and indeed the partnerships that we have with local authorities and with the third sector. And that idea of joining up services around the needs of individuals and communities, integrated care, if you want, is at the heart of what the changes to the health service are all about. So actually, the pandemic has not only underlined why it's so important for the reasons that Luke Evans was talking about earlier, it's also given lots of people permission to get on with doing it. The reality is this starts and ends with patients and with communities, and all of the rest of it in terms of governance and law and all the rest of it is just a means to that end. And ultimately it will be you as Parliament that will get to create the legislative space for people to do brilliant things across the health and care systems.
So you would assure people out there that these changes are absolutely about getting a better integrated health service.
Yes.
And there is no...
And doing a few other things. I mean, as we've talked about in the predecessor, you were on, you were on the health committee at the time, Rosie, but not everybody else will have been. You know, we've thoroughly been through the proposals with the predecessor committee that we, the NHS, would hope the Parliament would consider. We'd like to see a change to the competitive tendering requirements on the NHS, the so-called Section 75 out of the 2012 Act. We'd like all that scrapped so that we can actually get on and join up services. So it really does take quite a leap of logic to suggest that the very thing that some of those folks have been campaigning for so long represents a move towards the destination that they fear so much.
You'll appreciate that MPs' mailbags are full of people who distrust that, and the fact that it is happening right now. I do appreciate that integration. We've seen some fantastic things in my constituency and in Liverpool about organisations working together, but I do think more needs to be done to reassure those who fear that there is an undercurrent, especially with all the private contracts and not being open and transparent as we may have been over various PPE and all that kind of stuff. So there is an element of distrust out there, and we are in a serious situation. So your reassurance repeatedly is what's needed.
Thank you. Thank you very much, Rosie. Graham Stringer.
Thank you. So Simon, you've shown today that you're a clear and precise communicator. Do you think you've spent enough time in front of television cameras and microphones sort of explaining what is going on, particularly as there are so many myths about what is happening and about the virus itself?
Well, thank you for that question with a slight sting in the tail there, Graham. I mean, I think first and foremost, you know, I and everybody else in the health service are, you know, knuckle down, getting on with the job, which is actually trying to ensure that the health service does as good a job as we possibly can for people with coronavirus and all the other needs that we are here to provide, as well as now going on a vaccination. And there have been lots of people who've been willing to take to you know, TV and media and all the rest of it through this. We've actually got a day job to do. However, I'm in no way reluctant to get up and say that when you know, people need to hear it straight, I will do that. I did that last Sunday on Andrew Marr. I've done that a number of times before parliamentary committees and indeed at number 10 press conferences. But you know, like most of us in the health service, our key responsibility is getting on trying to provide top quality patient care as best we're able, as against some of those other responsibilities. But always happy to take guidance.
It was a compliment, and I do think just the fact that there are so many myths out there, people going into hospitals saying people aren't really poorly with this, that you, because you're so good at it, you should do more. But just in terms of the communication strategy, I have found it difficult to get information out about both people with COVID and other impacts of the epidemic on the rest of the health service from local trusts, because they tell me they have to go through a very tight central PR control. Is that the case? And if so, why? Because it is really slowing down very useful communication from people at a local level.
I mean, I think if you look at the TV news over the last 2 or 3 weeks, I mean, frankly, it has been dominated by news crews that have been in hospitals right across the country. So I don't think anybody can suggest that there's not complete openness and transparency to what's happening inside our hospitals and inside our critical care units around the country. It is certainly the case that when we are in one of these national emergency incidents, then we try and coordinate the information to make sure it's accurate, because otherwise what sometimes happens is you get somebody popping up with something that then causes all sorts of concern but it's untrue. A case in point being actually one of the early questions I got today in this session, which is it the case that if you're a member of staff and you don't have an NHS number, you can't be vaccinated? See, that was somebody popping up saying something untrue. Ran as a story online, got a whole load of pile-on people being very rightly concerned about it. So, you know, we just want to try and be as accurate and consistent in our communications as we can be, while also being transparent so that everybody can see what's going on inside the health service. And that's you know, the balance we're constantly trying to get right.
Would you accept that you may have got the balance wrong? Because sometimes it is just, I know the information is their interests, but it goes to the centre and it gets stopped. For instance, I've tried to get out both the local and total costs and the number of patients that have been treated in Nightingale units, and I found that impossible to get both to the GMX Centre in Manchester and nationally. Are those figures available? And can you either, don't expect them to have them, you to have them off the top of your head, but can you send them to me?
Yeah, no, they are available. And in fact, I'm pretty sure that they've been answered in a parliamentary question within the last week or two, I think. And I mean, I take your point, Graham, but equally, I would say that, frankly, we publish more data in real time about our health service than any other health service in the world and any other public service in this country.
A very similar question and final question. You said earlier in an answer to a question to Zara, that I think it was Zara, that the information on the number of people from different ethnic groups who've been vaccinated was kept. My local public health teams have told me that those local personal informations they found impossible to get. Where would I find that information? Has there been a parliamentary question on it? Is it on your website? Or where would I find that information?
Sure. So we've obviously got to be, so the first thing to say is that Directors of Public Health, I think I'm right in now saying this, are twice a week getting the upload of their own data. So I think they get it on a Friday late afternoon and on a Tuesday. And that is now broken down to not only the borough level and the district level, but to what is called the median super output area level, which I think is an average population of 7,200. So very localized, but done in such a way as to protect the confidentiality of or the identifiability of individuals within that small area. So those data are continually being refreshed with more fields overlaid on them so that they've got access to those data.
Thank you.
Thank you. And finally, to wrap up, Greg Clark.
Thank you very much, Jeremy. Chris Whitty and Sir Patrick Vallance, in evidence to our committee, have said that we should look at excess death as being the most relevant measure of the impact of COVID on mortality. Do you share that view, Sam?
Look, I mean, I defer to Chris and Patrick on the science on that. I think the reason they originally said that was because of the potential for different diagnostic coding practices between countries. So I think that was the underlying reason for their suggestion.
Well, it was to capture the fact that part of the impact of COVID is on people with other conditions that get diagnosed, perhaps because they don't come forward for testing, and the pressures, as we completely understand on the NHS, on treatment. So the overall impact is beyond those people who specifically have died of COVID. I think that's the thought behind it. Yeah. So given that, and if we do want to minimise the impact on deaths, the JCVI have adopted a rigorous logic about the prioritisation, as we talked about earlier, looking very clearly at those at most risk of death and making sure they're vaccinated first. Is there a case for doing this, and have you done it, for which NHS services should be prioritised for being cancelled or postponed first? So there's a rigorous basis for these decisions.
Well, I suppose our starting point was that for the NHS long-term plan, yes, we did that. We looked at the biggest causes of early death and disability across the population, so-called disability-adjusted life years, and that led us to say, here are some of the things where we think this country we can continue to do better, and that's where we should be putting particular effort. So that obviously related
during the
to
pandemic, when it comes to pressure on hospitals, should there be an order, just as the JCVI have done for vaccines, to say, these are the services that we close temporarily first, or we restrict, and these are the ones that we keep at all costs? Is there a consistent set of advice that you've promulgated?
Well, at the moment, so I think the first thing to say is that for sort of the most acute end of the spectrum, we're obviously aiming to, and I think are providing care for everyone who would benefit from it, and we've expanded surge capacity in order to be able to do that. And then, in addition to that, a clinical urgency has been the way in which decisions have been made about what order people should be treated in. So the discussion we were having earlier about some conditions that were waiting longer versus others that were being treated more quickly. But obviously, when we sort of get through this current wave and the pandemic, then we will need to take stock and say, as we look again at the shape of health need, has anything fundamentally changed about the way in which we thought about that through the long-term plan? I'm not actually convinced that it will have seen over the medium term, because I think cardiovascular disease, cancer, musculoskeletal conditions, mental health, these big killers and disablers are going to continue to be, even when the particular sort of infectious disease threat has hopefully retreated. So I think this will be more a question of ensuring that over the next month, 3 months, 6 months, patients are being looked after according to their clinical need and urgency. But I don't think looked at over, say, 5 years, it will fundamentally change the shape of what we need to get done in the health service.
Thank you. I was thinking more during the pandemic as to how hospitals across the country make these decisions and whether they could benefit from collective advice based on knowledge of what is going to save most lives.
Well, so the approach, as I say, is this relative ranking of clinical priorities, P1 through P5, which has been developed with the medical profession, including the medical Royal Colleges.
Thank you. And just finally, as you know, we're taking evidence to look back to learn some of the lessons that we can and that can be applied over the years ahead. And one theme that has emerged from some of our witnesses is how the armed forces can make a useful contribution in emergencies of this sort. And we saw that with the standing up of the Nightingale hospitals, with mass testing, and to a certain extent in the vaccination programme. Do you see a role for the armed forces on a standing basis in future national emergencies?
Yes, I mean, I think they've played a fantastic role alongside our NHS staff. I mean, we already have a sort of deep relationship with the armed forces, in as much as a number of our full-time NHS clinicians also serve as reservists in the armed forces, and a number of the armed forces medics practice clinically in the NHS. So that is a sort of synergistic relationship that we have built on. Over and above that, we have selectively been able to benefit from some of the logistics expertise of the armed forces. And look, in the round, I think we've got about 1.5 million staff working in the health service, and at the moment, I think we have about 1,800 people from the armed forces working alongside them, and they are making a great difference in every capacity in which they're supporting us.
And should that be part of the plan in future, that from day one, the army have a certain role in responding to a national medical emergency?
I mean, I think to some extent that has been the plan. obviously it depends on the other calls on the armed forces at any point in time, I suppose. So I defer to the Ministry of Defence and the armed forces on that one.
Okay, thank you very much. Thanks for your time with us this morning, and thanks again.
Maybe Greg, can I say, maybe the question behind the question is, should we try and build in more resilience into public services rather than running everything to the sort of optimum just-in-time efficiency? And look, I think that is one of the big lessons from the pandemic. We talked a bit about it earlier in respect of extended supply chains versus domestic manufacturing capacity, but that's just one instance of the broader point, which is resilience requires buffer, and buffer can look wasteful until the moment when it isn't.
Well, that is a very important theme of our inquiry, in which we're hoping to make some recommendations. Another one in the same spirit is whether the right response in an emergency is perhaps less a ramping up, as the expression has been, which is to say sort of gradually increasing over time, more than, if you can manage it, an explosive response that you do things everywhere, such as we're doing with the vaccination program, I might say. And if you have that model, it could be that the armed forces might be one way in which you can move in emergencies from a gradual incremental ramping up to something that has immediate impact simultaneously across the country. So that was what we had a session on pandemic preparedness, and there was a very strong theme that the armed forces were very good at that and should be built in as a matter of design.
No, I see that absolutely. All I would add is that I think from the point of view of hospitals, it feels like they've had an explosive repurposing of capacity since Christmas Day, quite frankly. Now, a lot of that was built on the work that was done over the summer and the autumn, both in terms of extra staffing, physical infrastructure, the partnerships we developed with others tackling the backlog, new treatments and so forth. But look, hospitals and indeed GPs have moved incredibly fast to repurpose the way in which they are interacting with patients. And look, this is not me saying it, this has been well commented by lots of other people looking in on the service. And I think in that sense, the NHS has rightly confounded those who expected it to perhaps move at a slightly more sedate pace. It's moved incredibly fast.
Indeed, and I think without anticipating our conclusions in our report, I think that is one of the striking features of how we've succeeded, where we've succeeded in this pandemic. It's been through that very rapid response, not least by your colleagues in the NHS. Another reason why we're very grateful to you.
Thank you, Sir Simon. You've been very generous with your time. Just a final question from me, if I might. In 1948, when the NHS was set up, it was a pretty traumatic time for the country. We were bankrupt just after the Second World War and so on. And we don't want to overdo the comparisons with now, but we have had a very, very traumatic time in this pandemic, the most traumatic time since the founding of the NHS. If we are going to turn this into another 1948 moment where we show real imagination in making some long-term reforms to the health and social care system, what would be top of your list for the things that you'd really like to change going forward?
Well, I think you touched on them at the beginning, Chair, which is that seeing health and social care as two sides of the same coin, and hence having a multi-year outlook for social care. And more broadly, I think, look, there are a series of economic pressures across the country. Let's start seeing the health service as part of the economic engine of opportunity, not just as something that gets spent on when you're deciding what your public expenditure priorities look like. We are an anchor institution in most communities in which we operate. We're a source of fantastic high skill job opportunity. We stimulate and sit alongside a life sciences industry, which is going to be a huge part of what the 21st century needs to be. And so view the NHS not only, hopefully, as a highly responsive, high quality health service, but view us as part of the economic dynamism that this country needs.
So Simon, thank you very much indeed for your time this morning. Best of luck going forward to you and your team in the NHS. We're very grateful to you for spending time with us this morning. That concludes this morning's session. Order. Thank you.
Committee Room 6, sound. 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 Committee Room 6, sound.